Now we look into a nasal cavity. Here below we see inferior turbinate, middle turbinate, perpendicular plate, vomer, cribriform plate. It really is a very narrow route up to the cribriform plate. And we see in the back here a superior and a supreme turbinate. So now we look in and we're on right side, septum, and with the endoscope, a inferior and a middle turbinate here. We see the middle turbinate attached laterally to the ethmoid. And then we pull the middle turbinate toward the septum, and here's the uncinate process. We begin to see that. What is that structure? Here's the turbinate. We're looking in the middle meatus under the turbinate. So here's middle turbinate. Here's the uncinate process of bone. And then back of it, you begin to see the bulla. And here when we retract that turbinate, these are anterior ethmoidal air cells. And to get to the anterior fossa, you have to work through those, so that here we're down in that sulcus behind the uncinate, the air cell, and we get into that area behind the uncinate process. We see the drainage of the anterior ethmoidals and the frontal sinus, and then we can divide that uncinate process, pull it over laterally, and we see how big these ethmoid air cells are. You can enlarge the maxillary duct opening out of the middle meatus. And here's a large opening into the maxillary sinus. This is the anterior ethmoidal air cell. The septum is here. And then we look above, we see a superior turbinate, and then above that, a supreme turbinate. So you get a chance to look at this. As you look at the lateral wall of the nasal cavity, in this area, above the palatine bone, we see the sphenopalatine foramen and the anterior opening of the Vidian canal. Here's the other side here, maxillary sinus, left side, sphenopalatine foramen. You have access to the lower clivus, and just a view up the nose at the cribriform plate. And this really is a very narrow area, so that to get it exposed, you have to open over it through the ethmoids and work your way back. So here we made an opening in the ethmoid air cells on the right side, the opening into the maxillary sinus, inferior turbinate. The middle turbinate is pulled medially. So this is all middle meatus. And now we see cribriform plate. Here are the ethmoid air cells. And you can work through this complicated maze of ethmoidal air cells. Here's cribriform plate. So by going through that, you see how much on just one side, by opening the ethmoids, how wide an opening you get. And the bone here laterally on the ethmoids forms the medial wall of the, if you open this, you're into the, anyone? Orbit. So here we've opened the ethmoid air cells on both sides. You can also drill out the frontal sinus from below. This is just looking up into the frontal sinus from below with an angled endoscope. Here's the anterior edge of the cribriform plate. And coming through the ethmoids is the anterior ethmoidal arteries. Back here are posterior ethmoidal arteries. You look back into the sphenoid, this is optic canal, and a spontaneous dehiscence over the carotid artery. And here is sphenoid process of palatine. So this is Vidian canals. But just a view, a panoramic view of all of this area you can get into by opening sphenoid, ethmoid, frontal sinus from below. If you need a large pericranial flap after you've worked in these areas, well, you can just drill a little opening here in the frontal bone, take a big pericranial flap without doing a craniotomy, and you can fold that flap all the way back, depending on how big a flap you take, all the way back to the sphenoid sinus through this area. And you have access down to C1, C2, just a view of the sphenoid, the Vidian canals, sphenoid process, V2 here, V3 back in infratemporal fossa. So coming through this area after the ethmoidectomy and drilling out the frontal sinus, you can do an osteotomy around this area. Here are the ethmoidal arteries and nerves. You can do an osteotomy around this area. Here's the olfactory mucosa setting just below the cribriform plate. And here we preserve the mucosa right at the plate, the anterior ethmoidal arteries. And here we've completed the dissection on one side, the olfactory bulbs. You have to divide the falx if you're going to open this area above. So the falx is divided, and we see the bulbs here. And so this is approach to anterior fossa. You can work back to the area of the sella. The olfactory mucosa is right here. And I don't think it's ever been done, but someday someone is going to open this area, leave the olfactory mucosa on the bulbs, and then let those nerves fall downward and close the anterior fossa and pull the bulbs up so they're exposed in the roof of the remaining nasal cavity and preserve olfaction. Maybe one of you will do that, but that's a frontier for the future. We're going to talk about transsphenoidal approach. And I started doing transsphenoidal approach coming sublabial under the lip, and then I switched the approach to coming along the nasal septum under the mucosa between the septum. And then I realized as I looked up the nostril with a microscope, I could see medial to the turbinates, lateral to the septum, directly to the face of the sphenoid. And I started doing this direct endonasal approach where we don't disturb any of the septum. Here we see the inferior, middle, superior turbinate in the lateral margin of the exposure. If we remove that, the upper turbinates, we see the medial wall of the maxillary sinus and the orbit in this area. If we move laterally, we're into maxillary sinus, orbit, and we want to stay out of these areas. Here, along the sphenoid sinus. Along the floor, we see the vidia nerve. In the lateral wall, we see V2 becoming the infraorbital nerve. And as we move laterally, we're into orbit. Well, when I started doing this direct endonasal approach, we came through the nostril. We didn't strip up any mucosa on the side of the septum, and we went with a speculum directly to the face of the sphenoid, so that if you look from above through the cribriform plate, this is the septum. We place the speculum along one side of the septum, and then we just crack some of the septum, the packed part, off of the face of the sphenoid, just below the sphenoid ostia. And the part that's separated is only about 1.5 centimeters in height. And then we open the sphenoid sinus. And the best guide to the midline is this crest on the face of the sphenoid. And these speculae, when you put them in, why they open, actually, the blades can separate as much as 3 or 4 centimeters, but you only want to open them wide enough. Here in this area, the optic canals are only separated by about 2.5 centimeters, so that you don't want to open them much wider than 2 centimeters, or else you can get fractures into the optic canal in this area here at the orbital apex. And the best guide to the midline is always this crest, medial to the maxillary sinuses, where the perpendicular plate of the ethmoid and the vomer attached to the front of the sphenoid. Today we often use image guidance, but by the time you get the drapes and the fiducials on, if you look at your image guidance and it says to you, this spike on the face of the sphenoid, below the sphenoid ostia, if it says that's off the midline, it's usually your image guidance that is off. This is just virtually always directly in the midline. It's the best guide to the midline of the sphenoid sinus. And as you look into the nasal cavity, the biggest obstacle to getting into the sphenoid sinus near the midline is the posterior part of the middle turbinate. It bulges over, and it tends to deflect the speculum to the opposite side. And if you get caught on this crest on the face of the sphenoid and open the speculum, it's little more than 1 centimeter over to that optic nerve and the optic canal. So you always want to push this posterior part of the middle turbinate laterally. Some surgeons resect it, but I've never resected that in a transsphenoidal approach. But you want to get the blades of the speculum positioned in these lateral gutters on each side with a crest of on the face of the sphenoid directly in the midline. And then once you come to the sphenoid sinus, for years I've watched people open the sinus, take out the mucosa in the sinus, but if you remove that mucosa, you have dura next to the aerated sinus, or bone directly facing the sinus. Usually when we do a transsphenoidal procedure, we take out the tumor, close the anterior cellar wall, and leave the sinus open to drain into the nose. If you pull out the mucosa and look in 6 weeks later, you don't have that normal ciliary action in the mucosa that sweeps mucus and other product out the sphenoid ostia. And you look in 6 weeks later, if there's no mucosa in the sinus and there's granulation tissue, pus, mucus, often the patients complain of a foul-smelling odor, while if you leave the mucosa intact, just open it on the face of the sphenoid and on the anterior cellar wall and look in 6 weeks later, the sinus looks perfectly normal. But if you take it out, it looks like granulation tissue. And when I started doing this direct approach, we came to the face of the sphenoid here, and then we removed the tumor. We had not stripped up any mucosa here on the septum, and I was packing the nose initially, and I asked myself, what am I packing after I close the cella? Why do I pack the nasal cavity? I'm not trying to put any mucosa back in place, but the reason I was packing to prevent bleeding, and the most common side of postoperative bleeding after transsphenoidal surgery are these branches of the maxillary artery that come through the pterygopalatine fossa and supply the nasal septum, so that if you get good hemostasis in this area, in these lateral gutters, once you close the cella, there's no need for packing. You close the cella, you leave all the mucosa you can in the sphenoid sinus, and then you can pull out the speculum. You're done with the procedure. There's no need for packing if you have good hemostasis here at the sphenopalatine foramen. Here are just the superior hypophyseal arteries. Here we're looking at the sphenoid sinus. We see Vedia nerve below. Here is pterygopalatine fossa. Always the carotid arteries bulge forward of the anterior cellar wall. We usually close the cella. We leave the sphenoid sinus open. If we come in off the midline, the first prominence we often see is the carotid artery. So even if you're using the microscope and a speculum, in order to make sure that the opening directly ahead of you is not a carotid artery, it's a good thing to have the endoscope available and to make sure that the prominence that you're looking at is the cella directly in the midline. With the endoscope, you can always identify the carotid prominences that are off the midline. Maxilla can be used as a route to wide areas of skull base. Here we're looking at the maxilla below the infraorbital nerve, and you can do a lower subtotal maxillotomy. It's a procedure that was popularized by Professor Robertson. I wouldn't say popularized, but it's not a common procedure, but it's a great procedure for accessing skull base. You can just deglove the maxilla, no incision on the face, And then you do a maxillotomy below the infraorbital nerve, come through the palate. It gives you infratemporal pterygopalatine fossa. Here we see nasal mucosa. You can retract that mucosa, work medially along C1, C2, lower clivus, and it gives you access to infratemporal pterygopalatine fossa, nasal cavity, upper cervical clivus. You can get to through the clivus, you can get to the sella or the anterior fossa using this lower maxillotomy approach. Another approach involving maxillotomy that you can access also middle fossa is the upper maxillotomy, where maxilla is open below a floor of orbit above the alveolar ridge, and it gives you access to infratemporal pterygopalatine, the nasal cavity, and then you can combine that with a craniotomy, a frontotemporal, that you can gain access to the cavernous sinus. It gives access along V1 to the orbit, V2 along the roof of the maxillary sinus, floor of orbit, or along V3 down to the infratemporal fossa. This approach here, the lower maxillotomy you can do for chordomas of the clivus, some of these juvenile angiofibromas. This approach, combining the upper maxillotomy and the craniotomy, exposure of cavernous sinus, can be used for some of the tumors that infiltrate along the nerves coming out of middle fossa and going into the skull base. Let me just run down the clivus quickly from upper, middle, and lower third. And dealing with clival lesions, you can do very focal approaches. And we'll start out here, lower clivus, just above the atlanto-occipital joint. And so that upper clivus is behind the sphenoid sinus. Here's the palate. Lower clivus will be here behind the, what is this that sits behind the medial pterygoid plate? What is that? We're in back of the turbinates now, and the lateral limit of the transnasal approach back in the nasal pharynx is the Eustachian tubes. And here's the tubal prominence. So that here, Eustachian tubes, if you remove a medial plate, then you can retract them laterally. And here we see lower third of clivus, clivus here, and a cup of coffee for anyone that can name this muscle that comes off the clivus along this tubercle, spans the atlanto-occipital joint, attaches to C1. What muscle is it? Rectus, capitis, anterior. In front of it is the longest capitis that you have to pull laterally. But here we've detached rectus, capitis, anterior. We know that on the inside of the petroclival fissure is the inferior petrosal sinus, but also there's a plexus of veins here on the external surface that runs down the fissure to the area of the jugular foramen. Here's the atlanto-occipital joint, and this nerve coming through above the occipital condyle is the, what nerve? Hypoglossal. Here is 9, 10, 11, and its joint, 12 joins them. You can open up then lower third of Clivus unilaterally. This is the kind of work we expect our fellows to do that come with us in the lab after their training. But you see the drilling of the hypoglossal canal. You can do a unilateral approach, vertebral, hypoglossal nerves, 9, 10, 11, intradural. And then you can extend the approach bilaterally, the paired hypoglossal canals. Here on each side, intradurally 9, 10, 11, the approach through the lower clivus. Here's a view over to the hypoglossal canal and jugular foramen here at the lower end of the petroclival fissure. The view with the endoscope angle laterally, endoscopic view, an intradural approach, and then the opposite side, 9, 10, 11, and then the 12th nerve coming through the canal. The view of the nerves just below the jugular foramen on both sides. And then we go to the upper third of the clivus, and to get there, you have to remove the posterior wall of sphenoid sinus. But here we see pituitary, cavernous carotid, optico-carotid recess. We've opened up the sella, half of it, dura exposed. We see anterior medial cavernous sinus here, superior hypophyseal arteries, chiasm. We see the basilar plexus and the dura of the upper clivus. Here, anterior medial cavernous sinus, 6th nerve coming through the dura, running then upward medial to V1, 3rd nerve, V2, sympathetics ascending on the carotid, and just right anterior medial cavernous sinus from 3rd nerve, V1, 6, V2, and left anterior medial cavernous sinus. And this is ophthalmic. It's not a bad approach for an ophthalmic aneurysm. You have proximal control down here. Just a thought. Here we see 6th nerve coming through the dura, running medial to V1. Here's a dorsal meningeal artery coming off the meningeal hypophyseal trunk. 6 here at dura, running lateral to the terminal petrous carotid. The arachnoid has been opened. The dura around the dural exit of the 6th nerve preserved. Here we open the distal dural ring around the carotid. We'll see that from lateral this afternoon. And what is this artery? What do we call these branches if they go from carotid to anterior surface of pituitary? They're not very common. They are McConnell's capsular arteries. Here we've opened that distal dural ring medially. We're under the diaphragm. And here we see along the sella, there's 2 layers of dura, a periosteal layer that faces bone, a meningeal layer that faces the gland and brain, and the sinus runs between those 2 layers. And then we can work along the side of the gland back to posterior lobe, along the edge of the dorsum, and then you can get in to the dorsum. Here's posterior lobe. Remove the dorsum, and you have the exposure through the upper third of clivus to basilar apex, to liqueous membrane, to posterior communicating, P1, posterior cerebral, mammillary bodies. And then you can expose middle third of Clivus here, one side, the opposite side. Anyone, what is this? What do you think? Vidia nerve again. And all of the early descriptions of vidia nerve surgery said sacrifice it. That can lead to a dry eye, but it's possible, I think we'll see it become more common in the future to not sacrifice it, but actually to drill it out and preserve it. Here it is in its canal, just like the hypoglossal nerves are preserved in their canal. But we see 6 nerves entering the dura here. You can drill off, this is petrous apex here in this area. You can get in with angled endoscope and work laterally to 7 and 8. Here, both 6 nerves at dural exit. You can look above with the angled endoscope and see 5 entering the mid-pons, 7 and 8 proximal to the meatus, but not a bad route if you could do a very focal approach to 7 or 5 right at the brain stem for doing a vascular decompression of these nerves. And here we see posterior root of 5, 7 and 8, 7 and 8 over at the porus then through the clivus. And here we come now to anterior medial cavernous sinus on the lateral side of the carotid, V1, V2, V3, and vidia nerve again. Coming to the terminal petrous carotid, some bone preserved around 6. And here's 6 on the medial side of V1. You can drill out petrous apex and get this exposure under the trigeminal nerve. Here's one of the superior petrosal veins. So working laterally, you can have an exposure of 5, 7 and 8, anterior medial cavernous sinus, 6th nerve in this area. We'll do a quick look at transoral and transnasal exposures of Clivus. And transnasal approaches for odontoidectomy are becoming more common. But here we look in nasal cavity. This is Eustachian tube. What muscle? Longus capitis. Clivus is straight ahead in the transnasal approach. Here we pull the longus capitis laterally, and we see rectus, capitis, anterior, crossing the atlanto-occipital joint from Clivus to C1. We're looking laterally with a 45-degree endoscope. Now we're coming transoral, and we're looking at uvula. You advance the endoscope, you see the epiglottis, and you open transorally. Instead of seeing the longus capitis, you see crosses across here from side to side, superior pharyngeal constrictor, and you have to look up with a 45-degree endoscope from the oral cavity to see the clivus. It's not straight ahead. Here's longus capitis, and this is longus coli muscles attaching on C1 with a band running up to the clivus. But this is transoral approach, and to get this view up to the clivus, we even have to angle the view upwards, while if you come in transnasally, you're looking straight ahead at longus capitis, clivus, C1. And again, the transoral approach, you're looking sort of at the lower part of C2. If you angle upward, you can see the odontoid and C1, but it's hard to get up coming transoral to the area of the clivus. You might split the soft palate, but you don't want that. That has its own group of complications. And here, if you come transnasal, you're looking straight at the odontoid, and we see what ligament? Apical and alar ligaments, and here transverse. And while if you look transorally, you're looking at the base of the odontoid, and everything is sort of foreshortened compared to looking at it straight through the nasal cavity. So you look upward. Here's drilling out the odontoid straight ahead, while if you look at the odontoid transorally, even looking upward with the endoscope, everything is foreshortened here. And here's transnasal now. You can look at the base of the odontoid. You can see it, the synovial joint on the odontoid here on the back side, the transverse ligament, alar ligaments. While if you look transorally, you don't have that view of the base of the odontoid. You're looking up between the alar ligaments, while transnasally again, you see the lower slit above the resected odontoid, the lower slit here of the cruciform ligament, while if you look on the view, again, transnasal, you see the lower part, and you can get sutures around the ligament. But while you look transoral upward, you don't see that odontoid. It's out of the view, and that lower slit of the transverse ligament is out of view. And then you can resect the ligaments, and you have the tectorial membrane that crosses the foramen magnum, attaches to the clivus, the atlanto-occipital joints laterally, so that with the transnasal approach, you get access to all of this area. This is the view that you get transorally looking upward, but with the transnasal approach, all of this anatomy is straight ahead, down to C2, all the way up to the planum. Transoral view, but it's hard to work upward from the oral cavity with a 45-degree endoscope. But the areas that can be approached with the endoscope. Thank you for sticking with me through this long ordeal.